Yes, ma'am, we are live now.
Yeah, okay. A very, very warm good evening to everybody. It's really a pleasure to welcome all of you. The CME program on adolescent health. This program is done by OGSSI along with our societies in the north. So that is the benefit of our webinars. We get to interact with people all over the country. I welcome all the panelists who are here for this seminar today, the CME on adolescent health. It is really a proud privilege to introduce to you all Dr. Jayarani Kamaraj Madam, who is the Director of Akash Fertility Center and Hospital. Madam is the winner of the Best Doctor Award, winner of the Rajamani Janakiraman University Prize, Dr. Vadamalian Endowment Gold Medalist, and various other prizes. And she is a lifetime member of FOGSI, lifetime member of American Society of Reproductive Medicine, lifetime member of ESAR, member of European Society of Reproductive and Embryo, ISHRE. Madam is presently the president of our OGSSI, Obstetrics and Gynecological Society of Southern India. I request our president, Dr. Jayarani Kamaraj Madam, to give the welcome address.
Thank you, Vijay. Thank you for the nice introduction. At the outset, it gives me great pleasure and honor to welcome you all for this webinar, which is a webinar conducted by our Obstetric and Gynec Society of South India, which is focused on adolescent health. It is the Adolescent Committee of Obstetric Gynec Society, does along with many societies from Rajasthan. So it gives me a great pleasure and honor to welcome you one and all for this adolescent health webinar. It is also endocrinology committee also was a part of it, but unfortunately Dr. Raki could not participate because she is just flying to Coimbatore. If possible, she will also join in the last part of this webinar. I welcome all the delegates here, and I have the immense pleasure to welcome the chief guest for this webinar, Dr. Kiran Pandey, who has accepted to be our chief guest in midst of her busy schedule to be a part of this. Madam is the chairperson of the FOGSI Medical Education Committee. She's the professor and head HOD of the GSVM Medical College, Kanpur. She's an ICOG Governing Council member of 21-23. And Vijay, can I have Madam's slide, please? CV.
Ma'am, can we finish the prayer first? Ma'am? Can we do that?
No. I'll just introduce and then, okay, right. It's up. I'll finish her and then we'll go ahead with the prayer.
Okay, madam. Okay.
Madam is the chairperson of the IMA of the Women's Wing in 2019 till date. She is the vice president of UPOG and UPAGOI, and she is the past president of Kanpur OBGYN Society and IMA, and she is the president of the Kanpur Menopause Society, and she has awarded a very many national and international awards, 75 national and 10 state level and 10 district level, and many IMA awards also. She has received the Best Teacher Award and the Best Kanpur Ratna Award, and she has awarded many awards for the Adolescent Health Committee at ACOG. And she has done a lot of original research in the field of cancer in collaboration with the Kanpur, and for the past 12 years. And she has more than 150 research articles published in national and international journals and 13 research papers on gynae cancers. And the madam is very active in adolescent health, and definitely she's the right person to be the chief guest for our webinar, which is a webinar on adolescent sexual health. So we welcome you, Dr. Kiran Pandey, to be the chief guest. And before we start, we always start with a prayer song. We want to felicitate our Tamil Thai. That is our prayer song. Vijay, can I have the prayer song? Sahiti?
Thank you, Dr. Jayarani, for very kind words.
I'm keeping it.
Very nice words. Yeah.
சிறந்த திராவிடர்கள் திரு தக்க சிறு பிறை நுதலும் தரித்தனரும் திலகமுமே அத்திலக வாசனை போல் அனைத்துலகும் இன்பமுற எத்திசையும் புகழ் வணங்க இருந்த பெரும் தமிழனங்கே தமிழனங்கே உன் சீரிழமை திறம்பியந்த செயல் மறந்து வாழ்த்ததுமே வாழ்த்ததுமே வாழ்த்ததுமே.
Thank you very much.
So, thank you, Sakiti, for this wonderful invocation song. And it gives me great pleasure to introduce the chief guest, Madam Kiran Pandey. Over to you, Madam, for it.
Madam, Kundavi ma'am, 1 second, madam. We have our secretary, our dynamic secretary of OGSSI, Dr. Kundavi Shankar, who is the head of the department and senior consultant at the M Hospital. Madam, I request you to kindly render the OGSSI prayer.
Thank you, Vijay. Thank you, God. In humility we gather. In gratitude we pray for all the good things you have given us. Shower us with your blessings to pass on the healing touch, to celebrate the arrival of each new life and a mom reborn, the courage to deal with it when all things are not perfect, and to remember that we are but messengers to keep our women safe and free from sorrow. We bow before your kindness and the magnanimity of your endless love. Thank you.
Yeah, thank you so much, madam. Sahiti, can I have the lighting of Kuttuvilakku? I request all the dignitaries here to participate in this virtual lighting of lamp. Thank you very much, Sakiti. Now this prayers, what we do, praying to our motherland, saying our auxiliary prayer, lighting the lamp by all the dignitaries here, all this gives us a blissful feeling and a good inauguration for this wonderful CME program. And the brain behind and the source behind and the energetic person who always pushes us to do things, our dear President, Dr. Jairani Kamaraj Madam, who's a big visionary, who's doing a lot of things, bringing in a lot of changes in OGSSI, all for the good of the society. Thank you very much, madam. Thank you for making us do a lot of work like this. Thank you so much for the welcome address. Thanks to Secretary, madam. Now over to you, Dr. Kiran Pandey. Yeah, madam. Jairani, ma'am, over to you.
So welcome, Dr. Kiran Pandey, for being with us. And I am very grateful for the presence here, the senior most faculties from Rajasthan, Dr. Sandhya Kumari, Dr. Taru Chai, and Dr. Sudesh Agarwal, who are very happy to join us in a short notice to be a part of this wonderful webinar. We welcome you, ma'am, to be for being with us, and also very thankful for the senior faculties here, Dr. Raki Singh and Dr. Josephine Rosie and Dr. Niveta Sivakumar, and the moderator of the panel, Dr. Sampath and Dr. Sunita Samal, who have accepted to be the moderators. We welcome you all, and also all the panelists here, Dr. Sandhya Kumari, Dr. Taru Chai, Dr. Premlata Madam, Dr. Selvi, Dr. Maheshwari, Dr. Meena, Dr. Mahajabeen, and Dr. Shobana and Dr. Sumitra, who have all been very happy to be with us for this webinar. And I also welcome the chairpersons, Dr. Rajalakshmi, Dr. Mohanambal Madam, Dr. Dhanlakshmi, Dr. Mangalam Bihe, who have all been here to join us to make this webinar a grand success. We welcome you one and all for this webinar. Over to your chief guest, Dr. Kiran Pandey, for your words of wisdom.
Thank you, Dr. Jairani. I hope I am audible properly.
Yes, ma'am.
Okay.
Yes, Kiran.
So at the outset, I'm really thankful from the bottom of my heart that you have given me this privilege and honor to be the chief guest of this wonderful webinar on the adolescent health. We all know this is a very important topic for and I'm really impressed by all of you, so many learned faculties and all the learned guests have joined here for this wonderful cause of the society, because the adolescents are the future of the country. Just a minute. So basically, they are our future and we have to look for their health only. They do face so many of the health issues, social issues, and they are not aware of the sexual activities, and the knowledge is not given. Many a times the parents themselves do not know how to guide them, and they get information from the peer, and that information is not always correct. So this is a very important initiative, as that Dr. Jairani and all of you, the whole team is working in this direction. I have been very passionately involved in adolescent health. This was not even once I was even planning to come for adolescent committee also. But before that also, for years together, I always loved to go to the schools, create awareness among the young girls who are not given any informations or right informations at their home. And many a times I observed when they were being given opportunity to come forward and interact, they were very happy. And there were questions one after the other. Even I was once remember in one of the my physical meeting, there was more than 100 questions, and finally we had to stop it. And although the coordinator was managing these questions once and all, but still there was so much curiosity. So that time, that was in the very beginning, I realized that these girls, young girls, and now even boys also, they do need, they have a craze and they want to know about the whole reproductive activity, the sexual activity. And it is our duty as a doctor, medical professional, that we should help them, guide them, so that they don't end up into the problems. We all know that if we do not give them the right opportunity, right information, they may end up into various complications, reproductive the issues, and even unsafe abortions, the communicable diseases, the sexually transmitted infections, even that. Well, luckily, when the HIV came, many places, every corner of the healthcare focused on that, and that gave us some at least advantage, or you can say edge over this problem, which could control it. So basically, the issue of the adolescent health in all perspective, they need counseling about the diet, they need counseling about the exercise, lifestyle changes overall. So many new diseases because have come up, like PCOD, because of the junk food, etc., environmental issues. So this all needs really, good concentration, focusing, and of course, sexual health is one of the important, which is a barrier, taboo in most of the families. There, the parents do not talk. So there, it becomes more specific that we should talk about it. So I'm very happy, and ma'am, congratulate all the societies, the Rajasthan societies and the OGSSI and their president, secretary, and the team, that they have taken this very important topic, and they will be discussing at various levels, and the esteemed panelists will definitely be able to give a very key messages to the practitioners, general practitioners, that they can come forward, they can go into the very exposed where the adolescents, they get exposed to them and teach them and create awareness. And once again, I would say I'm very thankful, and I'm really impressed by the whole of the program, which has been very crafted properly and systematically to create the awareness. And at the same time, my all the good wishes are with you, Dr. Jairani. I'm sure you are so active and you are already doing so much for the society. You will definitely be an asset for this to the folks.
Thank you, Kiran ma'am.
Thank
you so much. Thank you so much for your words. Definitely, as you rightly pointed out, adolescent age is the one where we are going to have the future society. The future world is with the adolescents. Nearly around 1/3 of the population, whole population is in the adolescent age. So we are responsible. We have a great responsibility to make them, to coin them, to shape them, to have a better humanity in the future. And they are going to be the future world population who are going to build up this world in the best way. So it is our responsibility to make them in the best way, both health as well as in the mental and in the sexual as well as in the social health, which is very important for the future world. So we thank you so much for sparing your time and giving your words of wisdom. And I'm really thankful on behalf of my society, OGSSI, as well as the National Endocrinology Society, as well as my adolescent committee. I thank you for being with us to give your words of wisdom. Thank you, Dr. Kiran.
Thank you. Thank you so much, Doctor.
Over to Vijay for the scientific session to be continued.
Thank you, Dr. Kiran Pandey, madam. Thank you, Dr. Jairani Kamraj, ma'am. We now start with the scientific session. Dr. Rajalakshmi is not able to join us. We'll have all the three chairpersons together for this session. It is a privilege to introduce to this gathering Dr. M. Mohanambal. She's a very senior professor who's been in government service for a number of years, 33 years in state government service and 3 years in central government service, and total of 44 years of medical education she has been with, and with an administrative experience of more than 12 years. And she is presently the professor of OBGYN department at Sri Muthukumaran Medical College. Welcome you, Mohanambal madam. It's a pleasure to invite Dr. Dhanalakshmi madam. She is the director, Sanjeevani Nursing Home, retired director of IOG. She has received the Lifetime Achievement Award from our Chief Minister and has conducted many awareness camps for adolescent health and cancer screening. And she is very interested in high-risk obstetrics. Welcome, Dhanalakshmi madam. And we have Dr. Mangalambike madam, who is the director of Bharat Hospital, a very senior obstetrician from South Chennai. Welcome, madam, for this conference, for this CMA program. I request all the three chairpersons to share this session. I will take the privilege to introduce the first speaker also, just for the this thing to share the screen. That is the reason. May I do it, chairpersons, please? Can I go ahead?
Mangalambike madam, you can introduce the chairperson. Madam is there. So madam can introduce Dr. Nivedita Sivakumar.
Mangalambike madam, are you there? Okay, so let us not waste time. It's a privilege to introduce Dr. Nivedita Sivakumar. She is an assistant professor at Chengalpet Medical College.
Mohanambal madam is also there, Vijay. I think madam is there. Mohanambal Munisamy madam is there. No, just call her, right? Okay, you keep going.
எல்லாருமே join பண்ணாங்க மேடம், ஆனா இப்போ என்னுடைய ஸ்கிரீன்ல காணோம். Okay, so Nivedita was senior.
Mohanambal madam.
Yeah.
Madam,
Yeah.
can you hear me, madam?
I can hear you.
Yeah,
I can
ma'am.
hear you.
Yeah, you can introduce Nivedita, ma'am, the first speaker. Her CV is online, ma'am. C is there. You can just.
See, I couldn't see introduce. Which speaker?
Nivedita Sivakumar, madam. The in the screen, her CV is there.
Yeah. She's a Nivedita Sivakumar is an assistant professor at Chengalpet Medical College, senior assistant professor at RSRM Lying in Hospital, Stanley Medical College, senior consultant in obstetric gynecology, Rainbow Children's Hospital. The area of interest is high-risk pregnancy, adolescent gynecology, and gynecological oncology. and for his achievement, 2 papers published in national journals and ICMR STS project done, presented papers and posters in national and international conference, membership at OGSSI Life member. Over to you, please.
Thank you, madam. I would thank Dr. Jayarani madam, Dr. Vijayalakshmi madam, Dr. PB madam for the opportunity given.
Yeah.
Thank you, Mohanamal madam, for my introduction.
Yeah,
I would
you're welcome.
Yeah, I'll share my screen now, madam.
Yeah.
Is it visible, ma'am?
Yeah, visible, nice.
Okay. So my topic for the day was setting up of adolescent clinics.
Yes.
So presently I'm working in a pediatric and a maternity hospital, madam. So it is a kind of a great opportunity for using this as a platform for adolescent health. I get to see a lot of patients from the pediatric colleagues who refer their adolescent girls to me for their first, gynecological checkup around when they are 10 to 12 years old, when they attain their first menarche. So that period is an excellent opportunity for us all gynecologists to, talk to those adolescent girls and talk to their mothers about how to, go on about their
menstrual cycle,
psychological health, but also the mental health and the vaccination, the HPV vaccination. It's an opportunity for us to talk about all these things. So I would like to say adolescence is a time when the very worst and the best impulses in the human soul struggle against each other for possession. So they are a very vulnerable group. They are usually a heterogeneous group as well. So there are a lot of factors that influence the adolescent health, say, starting from their family, the school, the society, we as healthcare providers. But the most important part that they play in their life is the media. So we tend to see a lot of adolescents being, influenced by the way the media is portraying the life of an adolescent average individual in any country. So they are mostly a heterogeneous group. So when we talk about adolescents, we just don't get the basic, normal child which is brought by the mother to our clinic, but we also tend to see some sexually abused children, those in conflict with law. They are a special attention that we have to give to some other group of adolescents as well. So we also have to tend to physically and mentally disabled children. We'll have to talk to orphans and those adolescents who also work due to their societal and family pressures. So when we as healthcare providers, where can our impact be on the adolescents is one thing which I would like to stress. Because schools can implement positive youth development programs. Parents can have frequent conversations, or in our country, parents usually do not talk as much as the adolescents, as much as the, issues pertaining to the health, about their health issues to the adolescents. But we providers can discuss the relationships, we can discuss the school experience to the adolescents, because it is only not about the gynecological concerns, but also the mental health issues and about their health or risk-taking behavior. So adolescent-friendly health services was a norm which was set up by the government of India. But when we as providers try to set up an adolescent friendly health service, like there are so many barriers that we tend to have. So these may be space constraints, the policy constraints of where we practice. It may be as simple as our attitude and behavior of ourselves and also our healthcare staff. It is also related to personal issues, like certain people, certain healthcare providers may not have the, the mentality to discuss sexuality or any gynecological issues. Say, for example, an adolescent is taken to a general practitioner, and they may not be well aware of all these sexual, changes in all the sexuality happening nowadays. So there might be some fear or shyness, etc., in them. So these might be some barriers which we have to face. And if we are planning to have an adolescent clinic or a teen clinic, So we should have a very good impact on our attitude as well. So we should be welcoming and friendly. We should always be knowledgeable about what we are going to tell, because it is a very sensitive issue. We cannot talk directly to adolescents about all those things. We should be very careful in the terms we use. We should be presentable. We should have a good communication skill. And the very important thing is we have to maintain confidentiality. Say if we are going to assign a certain days of the week or a certain hour of our OPD clinic for an adolescent, or a teen clinic, we should be punctual during that time. We should be understanding. We should be a good listener, and we have to be non-judgmental. So adolescent friendly clinics was even started by our government, but it is not as well taken up by the general population, because as these pictures depict, the adolescent clinics are conducted in one part of our general OPD in the medical colleges, or in the either the government or the private medical colleges, where we take in adolescents as a group. Either we give them a group counseling, or you make them in the other picture, we see that the health provider is having a group discussion with a lot of girls. But what we prefer is to have a one-to-one confidential and a privacy given setup, where the girl is free to tell her, gynecological problems or whatever health issues that she has to the provider. So there are a list of common adolescent concerns. So we can have a service package as such. We can display our scope of services outside our OPDs. Like we can tend to pubertal issues. We can talk about sexual and reproductive health. There can be other concerns for adolescents like psychosocial issues, nutrition issues, like immunization issues, where we get the opportunity to talk about HPV vaccines. HPV vaccine, in fact, is going to be inculcated into the national immunization schedule. In fact, Tamil Nadu is being the pioneer state, and we are talking about a single dose vaccine for HPV. If we have to talk about the cost factor, so we can tell them that this can be possible as well. So mental health issues, another very important thing, and we have to have the counseling about pregnancy issues, the teenage pregnancy issues, the MTP services, the sexual and the reproductive health education, of course, contraceptive advices that we have to give. And we see a lot of girls coming in with minor gynecological problems, say menstrual irregularities, a lot of white discharge, delay in puberty, or a precocious puberty, or a health and a body images issue. So mental health, if we take, that is a greater, domain which we can, refer to our colleagues, psychiatrist or a psychologist or simply a counselor. They can take care of the behavioral problems, the risk-taking behavior of adolescents. We see a lot of adolescents being influenced by media, like, having a selfie mania, taking selfies with a lot of risk-taking behaviors, this alcohol use, substance use, a lot of mental health conditions, poor educational attachment and such. So how to set up standards if we are trying to set up adolescent friendly or a teen clinic? So if we have an already existing clinic space, these are the guidelines given by the FOXY committee, adolescent committee. Yeah. So these are set up by an expert team, where they give us the ideas that we can reorganize our existing clinical space in a friendly manner, in such a way that we can set up a small space for the adolescents to come and, to sit, and you might feel that what if they are seen by someone else? They don't want to be seen. And we can decide upon the service package. We can develop a standard clinic procedure, say a clinical performer, for which the certain, the details can be gathered by a trained nurse who can not make them wait for long periods. The adolescents, they don't like waiting. They want everything to be done very fast. And we have to strengthen the skills of the team of the healthcare providers. We have to strengthen our skills as well, how to talk, how to have a proper attitude, non-judgmental attitude. And we can also go for outreach activities for demand generation. Either you can conduct camps in the schools or in the colleges, or we can have a public-private partnership, and we can involve NGOs or the non-governmental organizations as well. We'll always have to monitor the performance of the clinic too. So if we have a clinic with an existing solo practice, then cross referrals across branches, say for example to a endocrinologist, say to a pediatric endocrinologist, or to a neurologist, or to a medical specialist, might be a constraint. But this can be overcome by having adolescent friendly clinics when you have a practice at a big nursing home or a hospital. Then these can be easily tided over. So you'll also have to look at the location of the adolescent health clinic. Say very big hospital. The WHO standards say that it has to be accessible, affordable, and approachable by the adolescents. So if we have a multi-speciality team, for example, the multi-speciality team would include a medical team and a support team. So the medical team, we prefer a gynecologist, a pediatrician, and an endocrinologist. We have a lot of, endocrinological conditions like PCOS, precocious puberty or a delayed puberty, for which we can get an endocrinologist. And we need a very good support team, which has a very good trained nurse, a psychologist, a health educator, and a social worker. So even then, there might be some challenges in setting up an adolescent or a teen clinic. So first thing is a motivated provider. We might not be as much motivated to have an adolescent clinic, or we might find it very difficult to set out a lot of our time for the counseling of an adolescent, irrespective of the thing that we do a lot of OPDs throughout the day. Or it might be an unavailability of the healthcare provider, or an irregular availability, and a point on the adolescents as well. They might tend to cancel their appointments. They might not be regular to their appointments. They might think that this is not important, or they are not unwell, or there is nothing wrong with them that they have to come and get a gynecological appointment. Or they might be simply lack of information and communication activities. So as healthcare providers, we have done our part. But what can adolescents do?
Nivedita, 1 second.
Yes.
Isn't there a lot of disturbance in the background, or only I am hearing it?
Mohanambal, madam, can you mute yourself, madam? Mohanambal, madam, has to mute. Yeah.
Yeah, now, okay, Nivedita, yes, please continue.
Yes, ma'am. So we till now we have been seeing how we can keep ourselves equipped so that we do a friendly health service. But adolescents also, they can do their part. Like if they are from a very good socioeconomic status, they can always be accessible. They can find out how to access the local health services. They can ask their healthcare provider for more information, and they have to be aware of their privacy and confidentiality. And they can speak to a trusted adult. Now, most of the schools, most of the urban schools tend to have a counselor, or a guidance counselor, or a psychological counselor, or an adolescent counselor who gives them the, most of our schools have taken up the westernized culture. So they do have a counselor who can counsel or give information to the adolescents about where to seek help. A proper and a reliable source of help can be sought. And they should also not hesitate to talk about sensitive topics. So they'll have to believe or have to place their trust in the healthcare provider. They can always provide the feedback to the health center if possible. So how can capacity building and how can policy changes be made to improve adolescent health friendly services is like this. We can have frequent continuing medical educations. We can have orientation programs for gynecologists and pediatricians as well. And of course, our society, FOXY, has made a toolkit on adolescent-friendly health services. It can be downloaded on the internet, and the CD-ROMs are even available. Health policies can be formulated by the government for developing and implementing adolescent indicators. So one thing I would stress here is we have indicators for infant mortality rate, we have indicators for maternal mortality rates. or the indicators which tell us about the health of the neonates and the antenatal period. So the adolescents are the very vulnerable group where they don't have any indicator specific for them. We have under 5 mortality rates and we take care of our children under 5. But the group of children and the early adolescents and the early adults from 5 to 20 until they become pregnant, we do not have proper indicators or proper studies on them. So we can do exclusive data pertaining to the adolescent health issues in Indian scenario. That can be one of our advocacies which can be done by the government. And we can have a lot of guidebooks and training workshops done by societies like ours. And we can have a adolescent policy statement exclusively for that age group. And owing to this era of online media and social media things, adolescents can make use of online consultations and counseling can be considered. And we can also try podcasts on adolescent health. So virtual reality or augmented reality is a tool for counseling for adolescents, and it can be used as well. This is being used very well in Western countries also. So at this point, I would talk about the impact of artificial intelligence in adolescent healthcare as well, where we can make use of AI in the form of chatbots. Yeah, we know that the adolescents are fully on their social media, so we can try to develop apps or applications or search engine platforms where they can search for information, like, say, for example, where to go to the nearest adolescent friendly health center. And they can go to social platforms like Facebook, where they will connect the users who search for such friendly services. It can be brought to their smartphone, and it can have a proper ecosystem, and it can send messenger apps. It can remind them of their schedule with the gynecologist or a healthcare provider, with whoever they are, be it a gynecologist or a pediatrician or a healthcare counselor, where they can be used for a in-depth understanding by the tech-savvy adolescents that we say. While this takes care of most of the urban adolescents that I'm talking about, the rural adolescents are another high group strata which we have to take care of. That can only be done by creating awareness, is what I feel. So we have to go to their ecosystem. We'll have to go to their place, and we have to talk, give, spread awareness, and we can make use of the peer group educators, which is again a model which is applied by the government of India in training the peer groups, because the adolescents tend to listen to their peer groups, and they tend to rely on them for any doubts or any knowledge that they want to gather. So this can also be tried. So thank you for the opportunity. Now I would like to stress that adolescents are the greatest resource for a society to thrive. So investing in adolescents would bring us a triple benefit, because if they are healthy now, they would be healthy adults, and they would create healthy future generations as well. Thank you very much for the opportunity given.
Okay. Thank you. It was an excellent speech. A to Z, you have done everything. Next.
Mohanambal madam and Mangalambige madam, I request you, one of you, to kindly. May I request you to introduce Dr. Josephine, please? Mangalambige madam.
Yeah, he's going to tell. Can I carry on? Dr. Josephine is an HOD, Department of OBG, Madras Medical College, and Chennai Madras Medical College here. She's area of interest is high risk obstetrics, intrapartum care, gynec endoscopy. Achievement: published 2 international and 2 national journals. Have published in the poster presentation RCOG for verse 2020, and teacher for UG and PG revision courses in OGSSI. OGSSI, OGSSI permanent member of ATNRCOG and JACG WALS, IMA, CMS. Over to you. Please carry. Can you hear?
Yes, madam. Yes.
Yeah.
Josephine, ma'am, you can share, please. Mangalambige, madam, in
Yes.
between, we couldn't see you.
Yeah, that really, there was a problem because here it's raining.
Okay.
Yeah.
So I had a problem for a while. Now it's okay.
Okay, fine, madam. So only both of you are there, madam. Mangalambige, madam, and Mohanambal, madam.
Okay.
Dr. Rajalakshmi is not well, and Dhanalakshmi, madam's grandson is sick. So both of them couldn't join. So you both are there.
Yeah. Okay.
Josephine, ma'am.
I'm just sharing my screen, ma'am. One sec.
No problem. No problem. Okay. Madam is going to talk to us on menstruation in adolescence, heavy menstrual bleeding. Menstruation is a menace in adolescence. That's what's the topic. You want any help, madam?
Yes, ma'am. Shall I send it in one sec? I'm just
No, madam, there itself. But is your presentation already open? First, reduce, exit full screen from the Zoom.
Okay, ma'am.
Minimize the Zoom, madam.
Okay.
Now open your presentation.
Okay.
You are able to see your presentation clearly.
Yes, ma'am. Yes, ma'am.
Now minimize the presentation.
One sec, ma'am. Minimize the presentation.
Now you come to Zoom.
Okay, ma'am.
You can see a share screen green color button.
Yes.
You click that, your entire so this thing desktop will be seen, desktop or whatever, or this all the PowerPoint whatever applications that are open will be shown. In that you select your presentation. நீங்க ஷேர் ஸ்கிரீன் போட்ட உடனே உங்களுக்கு ஸ்கிரீன்ல என்ன மேடம் தெரியுது? எல்லாம் ஓபன் ஆயிருக்கு.
Microsoft PowerPoint unknown desktop 1.
அதுல உங்களுடைய ஓபன் ஆயிருக்கிற பிரசன்டேஷன் தெரியும் பாருங்க. நீங்க மினிமைஸ் பண்ணி வச்சிருக்கிற PPT அதுல தெரியும்ல.
One sec, ma'am. It's asking for me to grant access.
ஷாஹிதா கொஞ்சம் ஏதாவது அது கிராண்ட் ஆக்சஸ்னா என்ன
Yes,
பண்ணலாம்?
ma'am, I have given co-host permission to me.
It's asking me to go to system preferences and
ஏன்னா நீங்க எனக்கு அனுப்புறீங்களா மேடம்?
can I send in web WhatsApp, ma'am?
அனுப்புங்க.
One sec. I'm attaching, ma'am.
Okay.
I'm sending it in your WhatsApp, ma'am.
Okay, I'm waiting.
I have already sent.
வந்துருச்சு. Okay, madam. Josephine, ma'am, can you?
Yes, ma'am. Thank you so much, ma'am.
Welcome, ma'am. Go ahead.
Thank you so much for the wonderful introduction, ma'am. The topic for me given today is menstruation, is it a menace, on adolescent AUB. So as ma'am has already told a detailed explanation about how to set up an adolescent clinic. First of all, as we all very well know that as the World Health Organization says, the age group between 10 to 19 years will fit into the adolescent age group. And moreover, out of our total world's population, about 1/3 people belong to adolescent age group. Before going into understanding of what is abnormal uterine bleeding, let's have an idea about what is normal, and then we'll go to abnormal. So the normal frequency of any menstrual cycle will be 21 to anything between 21 to 45 days is normal. And cycle variation will be usually, for it to become regularized, it will take a minimum of about 2 to 3 years after your puberty. And the duration of flow, 4 to 8 days is a normal flow, and the volume of flow 4 to 80 ml is generally normal. So whenever we have to define what is an AUB, any bleeding which is abnormal in duration and volume and frequency. Any girl or any adolescent age group girl who's coming into our clinic tells us that she is changing her pads or tampons every hour or every 2 hours once, then it indicates it is excessive. So that is the thing that we have to remember. And moreover, 50% of gynec consultations that we get will invariably fall into AUB. As we very well know, the causes of AUB, we generally categorize into according to the palm coin classification, where palm belongs to only structural causes and coin for the non-structural causes. And in adolescent age group, non-structural causes belong to the main group of abnormal uterine bleeding in adolescence. So we have to think only about coagulopathies, ovulatory dysfunction, endometrial problems, idiopathic and not classified, usually will fit for adolescent AUB. Next, before going into the abnormalities, as we just a revision of our basic physiology, we very well know hypothalamus releases gonadotropin releasing our hormone, which stimulates pituitary to secrete both FSH and LH. FSH stimulates the ovaries to secrete estrogen, and also LH also will stimulate our ovaries. Basically, estrogen and inhibin, whichever is produced during the follicular phase, will go and inhibit the pituitary gland and the hypothalamus. So this is the normal mechanism we have to know. The next slide will tell you about the physiology that really happens. We very well know usually the follicular phase and the luteal phase. The luteal phase is always permanent only for 2 weeks, and there is only because of variations in the follicular phase of about 10 to 14 days, we do have a variation in the cycle length. Next slide, please, ma'am. Okay. Usually, I have explained about the causes compartmental wise. So the first main cause will be an immature HPO axis, that is hypothalamo-pituitary-ovarian axis, followed by hypothalamic dysfunction in any patient taking any antidepressants, antipsychotics, or any prolactinomas and all those reasons, and hyperprolactinemia will be the next cause, and any pituitary disorders will be the causes of abnormal uterine bleeding, followed by endocrine, basically thyroid disorders, any problems which causes anovulation, and coagulation disorders constitute about 36% of adolescent AUBs. Primary ovarian insufficiency, as I told you, medications like antipsychotics and depressants can also cause AUB. Sexually transmitted diseases are also very common nowadays because of the increase in sexual activity going down from the second decade. It has increased to the adolescent age group. So STD should be kept in mind, and rarely malignancies and uterine lesions should also be kept at the back of the mind. Next, before categorizing, we have to find out whenever an adolescent woman or an adolescent girl comes into our clinic, definitely she will usually be accompanied by her mother or relative or aunt, whoever. An adolescent, it is easy for an adolescent to know, it is not easy for an adolescent to know what is normal and what is abnormal. Sometimes when they don't know, more than the curiosity or more than the worry that the patient has, instead of hearing so many things from her mother would have told one thing, aunt would have told one thing, and her friends in school would have told one thing. So they'll really be in a confused state. So you have to categorize whether it is abnormal or not. This we can generally ask them a set of questions and find out by pictorial blood assessment chart. That is, you have to ask about the pad soakage, whether it is fully soaked, partially soaked, or it is very mild bleeding. So depending upon the soakage of pads, we can actually calculate by a formula where a score we have to calculate by multiplying the number of pads and the tampons by the factor whichever is present. If it is completely soaked for pads, it is 10 will be the maximum marks and 1 will be the minimum marks. If it is going to be a tampon, it is going to be score 10 for the fully soiled tampons and 1 for mildly soaked tampons. So whenever our adolescent patient comes into the clinic, as routinely, we will be doing a general systemic examination. We will want to check if she is pale and how is her pulse rate, and generally we will see for signs of anemia like tachycardia, hypotension, whether she is hemodynamically stable or unstable, whether she looks generally nutrition deficient or general malnutrition, undernourishment, everything we have to rule out. And then we have to do a detailed systemic examination. We have to check for her secondary characters about her height, weight, and general examination, systemic examination. You have to make sure that you auscultate and check for any signs of failure, any crepitation which is present in respiratory system. So these systemic examination should be from head to toe. A detailed examination should be done whenever an adolescent comes into the clinic, after explaining and taking consent from the patient and as well as the patient's attenders, whoever accompanies her. Next, once soon after we categorize, then we have to think about investigating. And in investigations, we just want to do a complete blood count where we want to check whether she is having any anemia. In case we identify she is anemic, we have to know about the kind of type of anemia she has by doing peripheral smear and blood grouping and cross matching. In case she is having severe anemia, we have to give her blood products. So we have to know about blood grouping and endocrine analysis by doing a serum thyroid stimulating TSH and a free T4. Coagulation screening basically to rule out coagulopathies. In case we are thinking only about coagulopathies, we will want to go into detail with von Willebrand factor, von Willebrand antigen, and factor 8 levels. And adolescent age group is an important age group. As we very well know, it is the transition phase between childhood and adulthood. We have to ask certain sensitive questions by addressing the patient, and as well as you have to interrogate the patient separately. Along with the attenders, we have to take some history, and sensitively we have to ask them whether they are sexually active. In case the adolescent agrees if she's sexually active, we have to do a urine pregnancy test and rule out pregnancy. Then serum prolactin levels to rule out hyperprolactinemias, serum testosterone and DHEA to rule out hyperandrogenism. And we should not forget about Bantus, because we are more common to have tuberculosis. So we have to proceed on with chest x-ray, sputum if the history suggests. The last resort will be ultrasonography. If you really think there is some structural cause for the abnormal uterine bleeding, then we have to proceed on with ultrasound. Ultrasound should not be the first investigation that we do. It should be the last one that we do. So whenever we have an adolescent AUB, indictimally 100% of all adolescents carry an ultrasound report with us. They are diagnosed of PCOS. They come and tell us to the clinic, doctor, I have PCOS. That's why I'm having abnormal heavy bleeding for the last. That doesn't hold good at all. Whenever we diagnose PCOS in an adolescent, we have to have two things mandatory. One will be ovulatory dysfunction and androgen excess. When will you say that a patient is having ovulatory dysfunction? Whenever her cycles are within a duration of more than 3 months duration, and if it is very frequent, less than 21 days or more than 45 days, even after 2 years post-menarche, and if the patient has no menses by 15 years, and even after breastbudding has occurred, but the patient does not have any menses 2 to 3 years after breastbudding, then we categorize she's having ovulatory dysfunction. Then how do you say the person is going to have androgen excess? If she's going to have moderate to severe hirsutism and an acne which is not responding to any medications previously taken, and if we document an elevated serum testosterone, then it indicates the patient is going to have both the things, then we diagnose an adolescent PCOS, which is leading on to abnormal uterine bleeding. So this is basically a slide which I have put to know about coagulopathies. I'm not going to take you into the detail of that. The main thing that we have to remember is the von Willebrand fact type 1, type 2, and type 3. Type 3 is the most severe one, which is autosomal recessive in a character. So any patient whom you think she will have coagulopathy, high risk of having coagulopathy, as soon as you diagnose by using a screening tool, you have to refer her to a hematologist for further treatment. The next slide, I have a very good questionnaire, which the questionnaire which will tell you how to identify women who are suffering from coagulopathy or at high risk of having coagulation disorder. So this will tell you if the patient gives history of having heavy bleeding since the day of menarche, along with any history of, in case any history of bleeding gums or epistaxis or any family history of any coagulation or bleeding disorders, then you identify, keep this as a screening tool and then refer her to a gynecologist. This is just a questionnaire in detail, will tell you what all I just told you now. So it is a detailed questionnaire which has 8 questions in hand. Next slide, please, ma'am. So it has so many questions. If the patient answers yes and everything seems to be fulfilling pointing more towards coagulopathy, then you refer her to the hematologist at the first hand. Next slide, please, ma'am. Okay, this is a screening tool which I took it from the ACOG in 2019. This is basically 4 questionnaires, 4 criteria are there. If any one criteria seems out to be positive, then you refer the patient to a hematologist to rule out coagulopathies, and we have to do certain coagulation important investigations to rule out coagulopathies. The next slide is going to tell you about the FOGSI criteria. This was taken from AOGD in 2022. So any patient complains of heavy menstrual bleeding since menarche, if the above criteria more than or equal to 1 criteria fulfills, like PPH nowadays, if she has a pregnancy and she has had a PPH, that is applicable. Otherwise, it is not applicable. Any bleeding after tooth extraction or bleeding after any surgery, if 1 criteria is there, then it fulfills positive screening. If there is more than or equal to 2 criteria, like bruising 1 to 2 times per month, frequent gum bleeds, or family history of bleeding symptoms, then we have to refer them to hematologist to undergo von Willebrand factor testing and ristocetin cofactor testing. Next slide, please, ma'am. So whenever you are going to have a patient with AUB, you have to categorize what kind of abnormal uterine bleeding she has, whether it is mild, it is moderate or severe. When do you say it is mild AUB? When the patient is having more than 7 days of bleeding, or the frequency within 3 weeks, she's have a second bleeding for continuously for 2 months. When the bleeding is slightly or moderately increased, but the hemoglobin levels more than 12 or it is somewhere between 10 to 12, you always advise the patient, reassure the patient that it is going to be normal. Don't worry. This is the initial phases that you are starting to have bleeding. So you please maintain a menstrual diary. So we can give NSA, non-steroidal anti-inflammatory medicines to control her bleeding for the initial 3 months. And then you ask them to come for a follow-up after 3 months. So when do you say the patient is going to have moderate AUB? When the patient is going to have frequent menses with moderate to heavy bleed, but hemoglobin is still maintaining more than 10 grams, then you can also treat them on an OP basis. But in addition to non-steroidal anti-inflammatory drugs, you can think about starting hormonal treatment in the form of combined oral contraceptives or progestins. So whenever you diagnose the patient is having severe bleeding, then the patient dictumly tells you that I change tampons or I change pads every 1 hour once. She looks anemic, she has signs of failure, or she's hemodynamically unstable with low BP, tachycardia. Immediately you have to admit the patient and you have to stabilize the patient. This is just a slide, and then admission along with oral contraceptive pills, either in the form of intravenous form, and once stabilization, we have to change over to oral route. So this is the gist of all the medical treatment regimens that is available for abnormal uterine bleeding in adolescent patient in the form of conjugated equine estrogen, combined oral contraceptive pills, medroxyprogesterone acetate 20 mg per orally, tranexamic acid, and desmopressin. Desmopressin will work out for patients who have been having coagulation disorders. It is given nasally. This will be prescribed by a hematologist. So then the patient will be subjected to routine check of von Willebrand's factor, because it increases von Willebrand factor to a greater extent. And whenever you are giving estrogen IV, the dosage is 25 milligram. It can be given every 4 to 6 hours for 24 hours for initial settling of the patient. Then we can switch over to oral contraceptives. Next slide, ma'am. Oh, this is just a scenario of any patient, adolescent. This is just a summary in order to say whenever an adolescent patient comes into the clinic with heavy menstrual bleeding, you have to check for blood pressure, pulse, tachycardia, hypotension, orthostatics, then do a physical examination, check for her breast development if it is more than or equal to Tanner's 3 staging, check for skin and external genital examination to rule out any sexually transmitted infections, to check out if the hymen is intact, ask her if sexually active. Skin, we rule out petty to rule out any coagulation disorders. In history, we do a pad count or a tampon count. We use the screening tool and then we go in for the lab testing. As I told you, all the lab testing has been enumerated again. Then depending upon the severity, if the bleeding is severe, then you do an inpatient management. If it is not severe, if it is mild to moderate, then you do an outpatient management. Whenever we are going to start a adolescent person with combined oral contraceptive pills, we have to rule out contraindications of giving estrogen. The main contraindications of giving estrogen will be any history of migraine with aura, any liver disorders, or any medicines that she's taking that will contraindicate or it will decrease the efficacy of the estrogen that we are going to give in combined oral contraceptive pills. Next slide, ma'am. So after ruling out estrogen contraindications, then we can put them on combined oral contraceptive pills can be given even 3 times a day till the bleeding settles. Then it can be tapered to once a day for 21 days. Then the patient will be put upon maintenance therapy. And then once we rule out anemia and then once we settle everything, then the patient will be settling very much well. But even after medical management fails, then the last resort will be undergo any surgical treatment, but that will be the last resort. So even after settling the patient with estrogen therapy or progestin therapy, depending upon whether she has contraindications or not, if bleeding stops, definitely we are going to discharge the patient. If she's tolerating peroral therapy, if usual side effects of taking oral contraceptive pills will be nausea and vomiting, so we can even consider giving antiemetics to this patient. We have to explain about the side effects. We have to explain about the contraindications before prescribing any medicines to these people. And then if she's going to continue with the treatment, you can also add antifibrinolytic, and then you can consult with an hematologist and even consider balloon tamponade, but that will be the last resort for these patients. This is about my presentation, but the take-home message from my presentation is any girl who walks into the clinic with an abdominal uterine bleeding, the first thing will be we have to reassure her. In case we find out she's anemic, we have to correct anemia. We have to identify the cause by doing appropriate lab investigations. We have to refer them early in case we are finding out they are at high risk of having coagulopathies. Hormonal treatment should be initiated only after ruling out contraindications for hormonal treatment. In case she's having a mild AUB, NSAIDs along with or without hormones. Moderate, you can consider giving hormones. Severe, you have to admit and stabilize the patient at the earliest and put them on follow-up appropriately. So this is about my presentation, ma'am. Thank you for the opportunity, ma'am. Thank you so much, ma'am.
And it was a very good presentation, given very in a crisp way, and it was complete. Congratulations, Dr. Josephine Rossi. It's very nice.
Yeah. Now we move on to the panel. May I request our chairpersons to continue chairing this session too? Can you introduce the moderators and the panelists, please? Mangalammihi madam, can you do the honors, please?
Yeah, yes.
This is a panel on physical, mental, and sexual health issues in adolescents, madam. The moderators are Dr. Sampath Kumari, Dr. Sunita Samal, and Dr. Sudesh would be the expert person giving the opinion. And we have a list of panelists here, madam. Madam, you can please introduce.
It's a very proud privilege to introduce Dr. Sampath Kumari, Professor Sampath Kumari. She's glittering everywhere, north, east, southwest, everywhere we can see her. Very smart. She is the Foxy Vice President South Zone, Founder Secretary TNFOG, National Correspondent Editor Joki 2021 to 2024. She is a Senate member Tamil Nadu, Dr. MGR University 2021 to 2024. She is the chairperson Foxy Adolescent Health Committee 2016 to 18, where she is rocking in the adolescent health, right person today. Deputy Director and Professor OG, retired Institute of Obstetrics and Gynecology, MMC. President, Board of Studies, OG, Tamil Nadu, Dr. MGR Medical University, 2015 to 2019. She is member, Board of Studies, OG, Meenakshi Medical University. She will never rest. She will keep on working. Now she has gone to private medical colleges. ICOG, Governing Council member, 2015, 2020. Madam, we are very eagerly waiting to hear you talk. I don't want to stand in between. Please. And here is Professor Sunita Samal, MD, FICOG, FMAS, ACME. She is a consultant obstetrician and gynecologist, Apollo Women's Hospital, 1000 Lives, Chennai. Former HOD, SRM Medical College Hospital, Katangulattur. UG and PG teacher for the past 16 years. Her special interest, laparoscopy, hysteroscopy, and vaginal surgeries, high-risk obstetrics, basic fertility, medical education. 50 publications in various national and international journals. Awards, Best Poster Award, ASOG 2015 and 2017. First prize in Foxy Zonal Quiz 2002. Dr. Anjalakshi Chandrasekhar Award for Best Research Paper, Oxycon 2020. International Scientist Award on Science and Medicine 2021. She organized CME, endometriosis, cancer cervix, adolescent gynecology, labor update, National PG Revision Program, Tamil Nadu chapter, presented paper and faculty in various national and international conferences, member of Foxy, Oxy, IAG, AMASI, ISU, OG. Welcome, Dr. Sunita.
Yeah, thank you, madam, for the kind words. Thank you.
And the expert, Dr. Sudesh Agarwal. He is the professor, former head of Department of Obstetrics Gynecology, Sardar Patel Medical College, Bikaner, Rajasthan, MD Postgraduate Institution of Education, Research and Training, PG, Chandigarh, Diploma Minimal Access Surgery, Kiel University, Germany, Fellow of Indian College of Obstetricians Gynecologists, FIOCOG, Fellow of Indian College of Maternal and Child Health, awarded many 12 gold medals for academic excellence, President of Bikaner Obstetricians Gynecology Society affiliated to Foxy India, published many papers in reputed national and international journals, invited faculty in national and international seminars, conferences, and workshops, special interest in perinatal medicine, prevention of maternal mortality. We welcome you, sir, for this session. We are eagerly waiting to listen to you all.
And we have the panelists, madam. Dr. Sunita Samal, madam, would you like to take over? I'll just screen the slide.
Madam.
Yeah.
Yes, ma'am. Yes, ma'am. Yeah. So good evening, one and all present here. And I, first of all, I would like to thank BG madam and our ever smiling Oxy president, Jairani Kamraj and Kundavi madam for this opportunity. And I thank also Mangalam madam for the kind words. So I want to invite all the panelists. So Dr. Sandhya Kumari Chaudhary, who is from Ajmer. Next, madam. Yeah, Dr. Taru Chaya, who is from the Jaipur Society. And Dr. P.B. Premlata, who is the HOD of Tagore Medical College. And she is active member in the Oxy and also a member of Adolescent Committee. Next. Yeah, Dr. Selvi, she is a consultant at Debaraj Manikchand Maternity Hospital, Sokarpet. and also a visiting consultant at Be Well Hospital, who is a former assistant professor in Meenakshi Medical College. So her area of interest is adolescent health and high-risk obstetrics. So Dr. Maheshwari, who is a consultant obstetrician gynecologist, a life member of OGSSI, ISR and IAG, and special interest is high-risk obstetrics and adolescent health. And then Dr. Mahajabin, who is a consultant obstetrician gynecologist, endoscopic surgeon at HIPAA Specialty Hospital. Dr. Sobhana Priya Sampath, who is trained urogynecologist at Kasturba Gandhi Government Kasturba Gandhi Hospital, trained in advanced laparoscopy at Coimbatore, and who is a consultant at Best Hospital, Kodambakam. Next, yeah, Dr. Sumitra Sundararaman, who is now the founder and director of Women's Health Division at Prana Holistic Center for Fertility and Integrated Medicine. Her area of interest is holistic treatment of infertility and women's health issues.
So you have a host of panelists.
Yeah, so I welcome all my panelists, and today we are going to have a panel discussion on 1 minute, madam. Adolescent health issues. I think everybody has told so much regarding this adolescent health, and now I'm going to discuss few cases which are the real life cases. All these cases I have encountered in my OPD. So that is why it was put those cases, and also I will have to some comments from the panelists, some opinion also from the panelist and also from the expert. So why should we talk about the adolescents? Why we have so much we are talking about this? Because they are the 1/5 world's population, and 85% of them lives in developing countries. And if you see India, the 23% of the Indian populations are adolescents. And all of us knows adolescent, it is a transition from the childhood to the adulthood. It's a different phase of life. It causes rapid physical, psychological, and also emotional changes. So it is quite exciting, but yet it is very much confusing for the younger adolescents. And it's a difficult and important phase of growing up. And it's also important to be aware and informed what is happening to these adolescents. So WHO defines, I think already this definition has been told, 10 to 19 years, and youth is 15 to 24, and young people 10 to 24 years. So we are going to address this almost this 10 to 24 year age group people. And during this adolescence, they have a lot of questions in their mind. So what is meaning of this growing up? Even our parents also tells you are now growing up, you have become a teenager, all those things. So they also wanted to explore everything. Everything happens new in their life during this stage. They wanted to know what is the puberty and body image and the self esteem. And there is also a lot of things happening in the reproductive systems and in the body image, special lot of things that happens. So they have also a lot of queries regarding this adolescent age. And what is the importance? Because as I told, developing countries, maximum number of adolescents, they stay in the developing countries. They are the parents of the next generation. And nowadays, all these girls, they're attending early menarche because of our lifestyle and the food habits and the environmental changes, and also late marriage, and they are more career oriented. And there is more of urbanization and migration from the rural to the urban places. Less family influence, and as you can say, it is a family influence or a nuclear family, and exposure to a lot of mass media. And what problems they encounter? Mostly the personal and the social problems of health and physical self-esteem, sex and reproductive health problems, and home and family related problems. So as you see, these are the importance of the adolescent health and what are the problems they sell. So we'll go to the first case. So this is a 19-year-old, actually my real patient. So presented with the complaints of white discharge PB on and off for the last 1 year, which was foul smelling, and it was associated with the itching. And she is sexually active for last 1 year. So now I just wanted to ask Dr. Meena. No, Dr. Meena is not there. Dr. Charu. So what could be the diagnosis of this case? What do you think from the symptoms, what this adolescence is having? What is the first diagnosis coming to your mind?
You are asking me, Dr. Taru.
Yeah, Dr. Charu.
I don't think there is no Charu, I think so.
Oh, sorry. So Dr. Taru Chaya. Sorry, madam. Sorry. So
the patient has come 19 years old.
Yes, madam.
She has complained of white discharge off and on.
Yes.
She has itching as well.
Yes,
So
madam.
most likely some infection, vaginal infection she has attained.
Yes.
First, now which type of vaginal infection, that we'll have to examine. We have to take the detailed history, and she is sexually active also. So we
Yeah.
have to look for sexually transmitted diseases as well.
Yes, madam. Yeah.
So there
So-
can be the possibilities of bacterial infection, viral infection, and sexually transmitted disease. 3 types of infections they can have.
Yes, madam. Yes. So this patient, so she is like most probably it could be a sexually transmitted disease or any infection. And if you see approximately 20 million of new cases of the sexually transmitted infection, it happens in every year. And these young people around 15 to 24, they're responsible for the half of the new STDs which is happening every year. And 1 in 4 sexually active teenager has some sexually transmitted infection. So this, if you see, the situation is very grave, because lot of like these young adolescents, when they involve in the sexual activity so early, and when they don't know what are the like consequences of that, they so land up in the sexually transmitted infections. Okay. So Dr. Sandhya, can you tell me what are the types of sexually transmitted infections usually we encounter in a like young adolescents? Dr. Sandhya is there? No. So Premlata madam?
Yes, maybe bacterial, viral, or trichomonas like parasitic infection can be there, because she is having a foul smelling white discharge. More commonly, we will think about bacteria rather than the other infections.
Yes,
Anyhow, we will get the history. What is the type, how the foul smelling is, what is the color of the discharge, is it painful or not, is it associated with itching? All this history we have to elicit. Then we have to see the discharge itself, and local examination is also necessary to find out whether there is any ulcer, any erythema, or any swellings. All these things we have to examine, then only we have to come to diagnosis.
Okay, okay. So, Selvi madam, can you just mention few symptoms of like sexually transmitted infection? You know, these are the variety of like types of sexually transmitted infection can happen in the young adolescents. So, what are the common symptoms usually they present with? Selvi madam?
Sometimes they can have discharge. The type of discharge, we have to see whether it is white discharge or frothy discharge, yellowish color, foul smelling. So all that we have to see. And then we have to see whether there are any rashes or whether she has any discomfort because of the rashes, and where are the rashes present, and does she have any irritation in the genital area? Does she have any itching? Does she have any pain? And sometimes because of the itching, when they pass urine, they'll have some burning icterition also. And also whether there are any lumps or any lesions.
Okay, any lesion is there or not? Okay. So as you know, these are the types of the infection. Usually they present with some symptoms. So now this patient has come with these symptoms. So what we should do next? So Dr. Maheshwari?
Dr. Sunita, I want to add one more symptom to it.
Yes,
because
madam.
we have to ask, because she is sexually active, we have to ask her partner, does the partner have some problem after the sex?
Yes, madam. Yes, that I will come next, because I'm just showing her symptoms. What I told is correct. So I have asked also, and it is she has only single partner, not a multiple sexual. This thing is not there, and this partner is not having any problem. Whatever she told, partner didn't have any problem. So next, Dr. Maheshwari.
In this case, I would like to get more background information, like how, as he mentioned, it is persisting for last 1 year.
Yes.
Whether she has taken any treatment so far, what type of treatment she has received. And apart from the symptoms, I would like to gather more information regarding her menstrual cycles, because the STDs might present with intermenstrual as well as postcoital bleeding.
Yes, madam.
And apart from this, whether she's practicing any contraception, since she is suffering from STD, whether she's using dual touch method like a condom and as well as other contraception, because she might be at risk of pregnancy because she's sexually active.
So
and I would like to do a general and speculum examination. Sorry, sorry, ma'am.
No, she was not using any contraception. And the second thing, our menstrual cycles are also regular. Yes, what you rightly pointed out, we should ask all these histories also. And she didn't have any history of any postcoital bleeding. Okay, so we should go for a next, once you have gathered all this history, as all of you are told, so you should next for a inspection and also a post-speculum examination. And while taking the post-speculum examination, as you already you have mentioned, like to type of discharge, what is the color, and any lesion, everything already like madam has told already. So we should like this, then we can take a pap smear and also a high vaginal swab. And for this patient, the PAP, it is initially it came as a negative for any intraepithelial lesion or malignancy, and high vaginal swab came as chlamydial infection. Actually, this patient, I think in the Chennai, she has visited almost 30-40 gynecologists, and she has taken multiple course of antibiotics. By the time she came to me, and her chlamydia infection, it has happened twice, first it has happened and she has treated with the antibiotics, still it was persisting, and as I told, it's multiple course, and she finally went into depression because of this discharge, because it was continuously, and she used to tell sometimes it is yellow color, sometimes it is white color. She's so much stressing on those things, and still the discharge are persisting. So again, the pap smear, then initially I think HIV, HBsAg, BDRL, all these tests also we should do to rule out the sexually transmitted infection. For her, all came negative. But when the pap smear was repeated after 1 year, initially she had done, and it came as ascus. And then we repeated also, we did a HPV DNA also. So that came negative. So because it came negative, and we didn't allow advise her to go for any colposcopy guided biopsy. And so this is the history of the patient. That means anybody coming with a young adolescent girl, so you have to, as all of you told, you have to take a proper history, and then you have to do the examination, and you take a pap smear, high vaginal swab, and based on the report you should go for the treatment for the people. At this point, do you think like HPV vaccination has any role?
Yes.
Because anybody like that, Sona?
Because
when the HPV, yes, madam,
is negative, so we can definitely
we have to definitely talk about the HPV vaccine and the dose which has
doses we should advise.
Yes,
or two depending upon the company. And another important point is when she is having recurrent chlamydial infections, talk to her about her general nutrition, improve her nutritional status already, and the contraception and safe sexual practices are also very important, madam. When you improve the nutritional status and avoidance of removal of pubic hair and recurrence, how it can be prevented is very, very important, especially in a teenage adolescent.
Yes, and particularly this girl actually, she had only, as per her, she had only once or twice she had intercourse, and after that, because this infection started, so she didn't have any sexual activity with the partner. So and she is having a good her BMI was around 24 and good height, PGK is good, so that is nutritional factor was not there also. But still, as you told, this is a very important thing. We should advise them for the proper diet and taking care of the nutrition, and also to use further whenever they are having any sexual activity, to use the barrier, contraception barrier, so that to prevent again further from the infection.
One more thing I
would
want
like
to
add a note, ma'am, that as Dr. Taru madam was saying, that we need to treat the partner also, so that
yes, madam.
Yes,
the partner has been treated 1 year back, because after that she never had any intercourse. Actually, she had only twice. And this infection, because we were persisting, she never had the intercourse after that. But initially, when she had the chlamydia infection, partner was also treated along with that. Yes.
One more thing I want to add, ma'am.
Yeah.
Since she's having complaint of itching, so these girls, they come to us also, and they continuously go and wash every time with the shower.
Yes, madam. Yes, madam.
That is also very dangerous, and it's always humid and wet also, and it enhances, they get fine breaches that makes the infection deeper, so the infection doesn't go. So we advise them, counsel them not to do such
Yes,
things.
madam. This point you have raised is a very good point, because I have seen most of these adolescents, they come and tell they routinely use this BUS, Intivus, they do vaginal douching very routinely. So that
Exactly.
itself, like it was out, sir, our whatever good bacteria, that lactobacillus. So like, I don't know, they see this TBs, the internet, and they just do regularly for that. So we used to advise the patient, don't do regularly, don't use these things like regularly. So that, because your normal defense mechanism also, that will also you will lose. So that also very good point you have like pointed out, because I have, in my experience, I have seen many adolescents, they do all those things. So this HPV vaccine, yes, madam.
What about using prebiotics and probiotics in this patient to create resistance? I mean, create sensitivity.
Yeah, probiotics, because this patient is having repeated infection. So these kind of patients, they are a good, very good candidate for the probiotics.
Candidates.
Yeah, that you totally good.
We usually recurrent infection, we usually advise for 3 months at least.
Yes, madam. Yes. And so all of know the HPV like recommendation, like more than less than 15 years means you should give 2 doses, and more than 15 years you can give 3 doses. And nowadays even this Gardasil 9 also has come, which is like even it is protecting lot of high risk groups also, it is protecting. So this HPV vaccine, and this girl, she has got already first dose and second dose of the Gardasil vaccine, she has already got. Okay, thank you so much. But then what are the preventive steps you can take, Dr. Sovana?
First of all, madam, when an adolescent comes to start with, we have to, there are two, in my practice, I've seen there are two kinds of adolescents. One category who, you know, they are very open, they take things very lightly and they think they know everything. And they have a attitude to the way they talk. The other category who's a very closed children and who come with their parents, or who are very much worried even if they have a normal white discharge. So the second category, they may be using, as we discussed earlier, they may be using douching, they may be using you know, they have a false idea that shaving of the pubic hair is the ideal way to be clean, hygienic and all those things. First is be sensitive to these categories, what is in their mind, be very sensitive, take a history, and then talk about treat them, and then talk about how to prevent it. That is personal hygiene, avoidance of intercourse. Avoidance, basically it does not lessen the frequency. Depending on the patient, I would suggest avoidance of early intercourse or multiple sexual partners. And then in case we are not able to establish a rapport, then we have to be sensitive and say about the contraceptive methods which they can use, in latex condoms, or they can use also female condoms. And then slightly I feel we should frighten them a little bit about the consequences, long-term consequences of this infection, like what happens in future if they are going to have repeated infections which may spread up and they may land up in tubal blockage and all those things. That is what I would feel.
Yeah, it's a very good point. So that's what already you have discussed all these things. So we should actually educate them, like even if they have a sex also, whatever the things they are supposed to do. Thank you,
Ma'am.
Excuse
me, ma'am.
Yeah.
I have to add one more point. In case of persistent vaginal discharge, we should think about foreign body also in these cases. Like persistent vaginal discharge.
Because this patient, when she is sexually active, so first time when she came with the discharge, so already perspeculum examination done, and usually those patients who are sexually active, you do a perspeculum examination from them. So some even those who are not sexually active, they are coming with the complaint of persistent discharge, and you should look for the foreign body. What you told, it's a very correct. And I have seen one girl, she was a 5-year-old girl. She has come with a persistent discharge. She was treated by the pediatrician with multiple antibiotics. Then finally we got the patient and we did an examination under anesthesia. Putting a vaginoscope, there was a ground nut with the full cell. It was there in the vagina. Yeah. So as you told, particularly this girls, small girls are also these young adolescents. Sometimes this foreign body, we should rule out whenever they're not, because we are not supposed to do the perspeculum examination. That time, any persistent vaginal discharge, definitely we should check for the foreign body. As this girl is sexually active, so anyway we are doing a speculum, so most probably we won't miss any foreign body in this kind of cases. Yeah.
Yes, ma'am.
Yeah. Thank you so much. So we'll go for the second
Eager
case.
to know like how you treated her and what exactly she received the treatment earlier, ma'am. You were saying she was treated with multiple.
Yeah,
courses
this
of
patient
antibiotics.
particularly, she has taken all IV antibiotics starting from like the meropenem, imipenem to doxyflagin. Okay, and then finally when she came to me, I gave her again, I took a repeat swab also. Again, it came as like a chlamydia. So I have put her on doxyflagin for 2 weeks, continuously oral antibiotics. And slowly, and she was having lot of stress because of this vaginal discharge. And everybody had counsel her, because you are getting this chlamydia infection, as you told, you may get a T-ball block, infertility, all those things. And her mother was also worried, but mother does not know anything. So she used to come to me, she used to tell me, madam, please don't tell to my mother, you tell something else, because we have to maintain some confidentiality also. So, but now she's fine. And she's under now 2 doses of vaccine she has taken. 3rd dose she has to supposed to, but now she is fine, no discharge.
Dr. Sunita,
Yeah.
only one
Thank
point.
you. So now we'll go for the second. Yes, ma'am.
Yes. See, you have treated the patient. That patient has gone to more than 30 doctors and she has come to you. So she should have started the sexual activity before 18 years. So first you have to verify as per POXO Act whether police intimation was given. That is the only one point I wanted. She may tell that don't tell to the mother.
Yes,
but
madam.
now 19 years. So she is, you have treated that
What
partner
she told,
1 year
she
back.
told 1 year back only she had the first activity.
So the take-home message, whatever you have dealt, it is fantastic. The adolescents are like that. But if they are less than 18 years, you have to give the information and then start the treatment.
Okay.
That's
Ma'am,
all.
one more
Thank
thing
you.
I want to ask here, because the online consultation, almost daily I get 16, 17, 18-year-old. They call online consultation because they don't want to go to the like physical consultation. Unprotected intercourse for a emergency contraception. And
No,
some
don't
people
give.
also, they are having, some people they are having regular like intercourse, they ask for some contraception. So those kind of patients, usually I tell them to come for a physical consultation so that I can explain them. So what you should do at particularly that point, madam?
Don't attend that call. Ask her to come. But
I just
online consultation for less than 18 years, that too for sexual activity, don't give. Finally, no one will help us. POXO Act is against the doctors. So don't do that.
Even if you are given a small tablet, even on online consultation, and you have not informed, you are under POXO Act.
Yes, madam. Yes, yes.
You should be very careful.
Yes, madam. Yeah. Thank you. Thank you.
Madam,
for
I just want to add one more thing. Simultaneous treatment of the partner and advising abstinence during the treatment is also equally important, because
yes, ma'am,
infection again and again she'll be coming even after you give a complete course of medicines.
Yes, madam, that is true. This patient, anyway, she had only twice as per her, because I have like warned her very strictly. So she didn't have any contact, and that her partner was also not staying in Chennai now. So she didn't have any contact. So, but
did you give probiotics to her?
Yes, madam. She is on probiotic for last 15-20 days. She is taking probiotic. So come to the second case. So this is a 19-year-old presented with secondary amenorrhea for 3 years. She had her menarche at the age of 13. Her initial cycles are regular, and she didn't have any comorbid factor. She had the fear of eating. Her initial weight was like, her BMI was 23.8. But when she came to me just 1 month or 1.5 months before, her BMI is only 13.6. And when you did ultrasound is a normal study, like uterus, ovary, everything is normal with a good volume, and it is only 6 millimeter. And FSH and LH, it is like very low, like 0.86 and 0.1. So, like Dr. Sobana, what could be the diagnosis of particular this case? What you are thinking in your mind?
It's anorexia nervosa.
Yeah, anorexia nervosa. Within
Yeah,
a year, she's lost so much of weight, and obviously, it looks like anorexia nervosa.
Yeah, can you tell some symptoms? Usually, with what symptoms these people, this time, like anorexia nervosa, they girls they present with?
See, these adolescent girls are always preoccupied with their body image. So even normal body weight or lean girls, they feel they are overweight, And especially these girls with anorexia nervosa, there are two categories. One category, they will binge eat, and then they will take laxatives, vomiting tablets, and then they vomit and make sure whatever they eat comes out. The other category is that they don't want to eat even if the weight is normal or underweight. To such an extent that the fear of being overweight or their body image is a main factor to assess their own image, or their own, they value themselves with the body image. So this is how anorexia nervosa usually presents with.
Yeah. So this patient actually, she is kind of extreme, like her BMI is only 13, but otherwise she looks wise she was not looking like that sick, but her BMI is only 13.7. Yeah. So you will see, as you told, nowadays people are having that showing the figure of zero size. Like either they want to become a Kareena Kapoor or they want to become a Hrithik Roshan. And many of us know, like because of this dieting, and people see they don't meet a proper nutritionist, and online they see a lot of things. I think this is recently had happened, maybe within 1 year.
Correct.
She is a celebrity and she died because of the renal failure related to her keto diet. So a lot of, even we heard like a very young, like a male also, when they do vigorous exercise also, they died of a lot of cardiac issues. Now we are seeing a lot of people, this is happening. So this body image is very much important for them. So for that is the reason they do all this kind of things. And how do you like want to approach this kind of patients? Dr. Sumitra, sorry, Dr. Sumitra.
Yes, ma'am. This is a very sensitive issue which we have to handle. So we need a multidisciplinary approach where we need to take the help of a psychologist who's having experience in cognitive behavioral therapy and has treated such patients, because this is going to take a long time for them to settle down. And a psychiatrist, an endocrinologist, or a general physician who's taking care of adolescent patients. And along with that, we should be able to take a treatment, because this is not, this is more important, because we need to make them increase their weight. Restoration has to come back to their BMI. And so also we have to bring in the cycles again. So, so from our part of it.
Yes, madam. Yeah.
Yes. So, and we also require the help of a good dietitian who will put them on the right food, and also a fitness trainer who brings in the exercises. So it's a whole multidisciplinary approach is very important.
Yeah, so this patient actually we have given her like one cycle of, because ET was only 6 millimeter. So I have given her one cycle of OC pill, low dose OC pill. And she had like recently, she just consulted me online. So her weight gain, it has become like over a period of 10 days, she has gained 1 kg of weight. And that's a good sign actually. And she got her period also after one cycle of low dose OC pill. And she is now regularly attending the counseling session. So I like when she came here also we counseled. So particularly this kind of like this young age population. So we have to tell them they need much of like counseling, like psychological counseling is needed for them rather than any other treatment. And once they land up
body shaming or the concept of this thing, as you rightly pointed out initially,
yeah,
it is the main, because of the social media. Increased social media, they are more on the phones than looking at the person across. So
yes,
and among the adolescent, the talk is always among, you don't look good, or you have you have something on your face, or your body structure, upper part. They
are more like always posting pictures on Facebooks, Instagrams, so different yeah. So they are more prone. And even this patient, I'm telling one more patient like her. She was 90 kg. This is one extreme. She was 90 kg and she lost almost a period, over a period of 6 months, 40 kg she lost. And she came with, she came for a consultation because her, she lost most of the, breast tissue. So it has become now like a saggy and a very wrinkled breast. It is just looking like she was only 20-year-old. Her breast was exactly looking like one postmenopausal lady. So she has come with that complaint. So I don't know what to what kind of treatment has to be given for that. So maybe she has to, like I told you, have to gain little bit of weight, eat some food, and this drastic weight loss, sudden weight loss over a period of 6 months of 40 kg, it is not good for the health also. So you have to, like, that means counsel the girls regarding this weight.
Neither they're always seeing, sorry to interrupt, ma'am, but they're always seeing YouTube where 10 days you lose 10 kg.
Yes.
And then some home natural therapy, and they don't realize the side effects of it. I've had patients who lost 16 kgs and came with so much of burning, gastritis, UTI, loose stools. She was refusing to get away from all these home treatments which people are giving on the YouTube. And then they pay for them. They all are considered better than.
There's so much advertisement on Google that keto diet, you can give weight reducing pills and so many things. So they are mesmerized by that, and we have to counsel them for that.
Yeah. So if you come to this point, actually we should advise them. They should have a regular, like a healthy diet, what you prepare at a home. And they should go for a regular exercise and avoiding this fast food and the junk food. That is more important to maintain a normal weight. So because we cannot maintain and sometimes you give them diet chart also, but diet chart, sometimes it is not possible for them to maintain for a long time. So it is basically the moral of the story. They should take the homemade food, which is a balanced diet, avoid more of carbohydrates, and take more of protein and other kind of food, and do regular exercise. That is more important for the exercise, because nowadays like adolescents, they are always busy with the screen, either with the phone or with the laptop or something. So there is very less time for them they don't want to do any exercise. So that we should stress upon the diet and the exercise more rather than anything else. Yeah.
Also, I'd like to add one point, ma'am. Sorry to interrupt. Because this is a very long-term treatment approach. It's not going to settle over a month or so.
Yes.
So there's a lot of chances to relapse because they're always into social media. So the family support is very important, because they need the parents have to take responsibility in making sure that they are taking the right food and meeting the right doctors and getting the counseling and also the therapies they are meeting. Because most of these girls, they have their own ways of going. They are in.
They don't listen to their parents. They don't listen to their parents.
They don't want interference of parents as well. They don't want parents
to approach the peer group, ma'am.
Yeah, they don't do. But when medically they are unfit, the parents have to take over for that short period, at least till they are meeting the thing, and then probably.
Many times to the patient and ask him for regular checkup and regular follow-up. That is much better.
Yes.
I always say to my patients, burn the fat rather than dieting. So exercise is more important rather than dieting. That is the thing I always advise. Burn the fat.
And many times I have seen
anorexia. There is, in case it is not treated, means patient is not recovering, then we should look for autoimmune factor as well, because there is association.
Yes. So this girl actually, she is showing the positive sign, because over a period of 10 days, she has followed her diet, she listened to her mother, and she gained some 1 kg weight, and that's a good sign for her. And she got her period also after starting the OC pill, she got her period. Okay, so next case, already I think we have discussed regarding this patient case, but still I just want to tell, 16-year-old presented with irregular cycle once in 2 to 3 months for last 2 to 3 years. Menarche at the age of 11, her BMI is 27, and when the ultrasound has been done, it shows polycystic ovary. She also have this acne also, and also this neck sign, like all the pictures of hyperandrogenism. So Dr. Maheshwari, so what could be the diagnosis of this patient, this girl?
Already done.
Oligo-ovulation as well as the hyperandrogenism, clinical hyperandrogenism. I would like to say this could be a case of PCOS.
Yeah, so mostly it could be adolescent PCOS. Okay, so Dr. Mahajabin, so can you tell, is this adult PCOS, it's different from the adolescent PCOS? Is it different from the adult, or it is same? I think our first, Madam has already told, regarding this answer.
Yes, ma'am.
Yeah.
We have to see the ovulatory dysfunction and hyperandrogenism. either in the an ovulatory dysfunction, it may be an irregular cycle of more than once in 3 months or once in 4 months they'll be getting, or menstrual cycle of less than 21 days or more than 45 days, or a primary amenorrhea like more than 3 years after getting the breastbudding.
So that means basically before the 8 years of menarche, before that we should not use the pelvic ultrasound as a diagnosis of PCOS.
Yes,
as per the Rotterdam criteria, you tell any of the 3 clinical or the biochemical of hyperandrogenism and the like symptoms like oligomenorrhea or anovulation and polycystic ovary. But here for the adolescent, there should be 2. That means you should not take the ultrasound criteria as a diagnosis from the 8 years of the menarche. So that is more important.
Also in the initial first 2 to 3 years. Also in the initial first 2 to 3 years, because of the less maturity, the girl will be having an ovulatory cycle. So we can wait for another 2 to 3 years post menarche.
Yes, correct. So this is the ultrasound, and we know
the other causes of hyperandrogenism before putting her in the diagnosis of adolescent PCOS, there could be other causes for hyperandrogenism oligonovulation, like androgen secreting tumors or simple thyroid issues. I think we need to evaluate before confirming that she's suffering from it.
Yeah, correct. Yeah.
And one more thing, ma'am, whether she's on any other medication. Some anti-epileptic medications can also cause irregular cycles and PCOS-like picture. So the history, right from the history, we should start off and to decide whether she is a case of adolescent PCOS or some other issue.
Cause maybe. As you rightly pointed regarding the taking up like any other medications is taking or not. Even some people, like as you told, this mental health problems also very common. Sometimes they take
antidepressants will cause. Yes, exactly. Yeah.
So sometimes they take also, and particularly when you tell regarding the polycystic ovary, so the new definition of the polycystic ovary, like it should be like the follicle number more than 20 and the diameter of 2 to 9 millimeter, or the volume can be more than 10, and when there should not be any corpus luteal cyst or any dominant follicle should not be present. Because when you see the ultrasound report, each and every report is come as a polycystic ovary. Each and every regular ultrasound report has come as a polycystic ovary, and this is the strict criteria. This is the 2018 like ISRA guidelines to diagnose the polycystic ovary in either in an adult or in a adolescent. So what are the risk factors for this adolescent PCOS? Dr. Sobna? Dr. Sobna is there? Dr. Selvi?
Hello, I'm there, madam. Dr. Shobna.
Yes, madam. Yes.
It could be adolescent piece of lifestyle, weight. What is and there may be a family history of polycystic ovaries. So I think these factors itself predispose to PCOS-like picture in adolescents.
Yeah. So we always, that means for adolescent, like anybody having this, the main important factor is the lifestyle modification rather than any medication. So when you go for the treatment, Dr. Sumitra, can you just tell something regarding the management of this adolescent PCOS? BG madam, you want to tell something? BG ma'am? BG ma'am? Okay. So can you just tell something regarding the management of this adolescent PCOS?
The management is to get, as you rightly pointed out, ma'am, that we should not be using the ultrasound as a marker and use the, we need to diagnose the lab test and along with the clinical examination, where we have to also see the hirsutism, the how much of degree of it, and the lab tests we need to do, where along with the biomarkers for FSH, LH, prolactin, thyroid tests also have to be done. And also, we shouldn't forget that because it's a lifestyle disorders, a lot of insulin resistance among adolescents are coming up. So we need to look at that also because it's quite prominent. Along with that, pre-testosterone, and now AMH is also being used as a marker to rule out
but
PCOS.
AMH we don't use to diagnose PCOS, just with the sideline here. So it is not used as a diagnostic criteria.
Yeah, just coming to that. It's not used as a diagnosis, but but as a part of our treatment protocol.
Yeah.
But main management will be the lifestyle changes, where we need to look at ways to have a dietitian to do a proper dieting things to be told, and the parents also have to be counseled along with the child as to how the dieting habits has to be there, because it's very important that they all are involved in it so that the child can eat better, because otherwise
It's 21 hours.
they may not follow it right through. And a sensible exercise program is necessary so that they lose that weight to go about it. So the
In
life.
those cases,
And
if the
what about
patient is
combined
obese-
OC pill?
See, when the
Yes,
patient
ma'am,
is
I was
obese, we
coming
have
to
to
that.
divide into two categories. One is obese PCOS and non-obese
Lean
PCOS.
PCOS, yes.
So non-obese PCOS, they already not obese. So diet and this will not matter in those. So we have to go for hormonal treatment along with.
So combined
But I've seen even in lean PCOS, there's a lot of insulin resistant cases are happening. So I would suggest that lifestyle changes do play a role in both of them. We do think that obesity, yes, lifestyle, we immediately put them on this, but we think in lean PCOS it's not so. But actually, I've seen so many patients across that when I check all their parameters, lab parameters, I do find them, a lot of them insulin resistance. I had a 15-year-old yesterday with a HbA1c of 5.8 and fasting insulin at 34. So they are making and then I see that they are into junk food, and the mother didn't feel that it's important to give her. It's okay, she's just taking that. It's only once a week or something like that. They say they don't know how much the daughter is having it other than that from school to home. So they do play a role in both the things. So that way I would suggest both a regular proper eating, as you rightly said, and previously home food is the best one, and physical activity. Then coming on to restoration, regulation of periods, it is a combined COC pill is a better thing which will sensitize the estrogen and progesterone so that they have a regular cycle. And if there is an insulin resistance problem, we can consider giving metformin to along with the COC.
So because that guidelines has come for this 2018. So again, this first line of management, you can give a combined OC pill. Either it is a clear-cut diagnosis or patient is at risk. Both the cases, you can give the combined OC pill. And regarding metformin, in combination with the OC pill also, metformin could be considered when the BMI is more. And where the OC pill and the lifestyle changes, they don't achieve the goal. So there you can give the metformin also. And in addition to lifestyle also, it can be considered in the clear-cut case of adolescent PCOS for the metformin. But otherwise, initially we don't start with the metformin with all cases of adolescent PCOS. To regularize cycle, we give the combined OC pill. So Sampath madam,
excuse me, ma'am.
Sunita, I want to tell one. Yes, but tell.
No, ma'am. Marjorie want to tell something. Yeah, please tell, ma'am.
No, regarding that fasting insulin and HbA1c, that's not necessary for adolescents. If at all needed, you are going to rule out the thyroid, prolactin, and fasting and postprandial or DTT also can be done. So the fasting insulin nowadays, it has no value.
Yeah,
okay. That's what I want to insist also. Nowadays, we don't do it as a routine.
Yes, madam. Yes.
Most of the time, these insulin resistance is always associated with hyperprolactinemia also.
Yes. So routinely, we should do a prolactin, as you said. When you do a thyroid
and prolactin and blood sugar are more important.
Should we do testosterone levels, madam, in these patients?
Yeah, those who are having this hyperandrogenism, we are definitely have free testosterone.
Anyway, these people will be having hyperandrogenism.
Yeah.
So, is as a basic investigation, should we add in free testosterone levels other than thyroid function, prolactin, and GTT? Is it necessary?
This DHEA and this free testosterone, it can be added to the test because for this and when the patient is having a clear-cut clinical features of hyperandrogenism, and we should treat and also simultaneously also you can give the test, particularly DHEA and the free testosterone.
When there is
The
more
levels will help us to
more
rule out the
acne, you have
releasing
to do the
tumors, ma'am.
testosterone. Otherwise, it's not necessary.
Yeah. Okay. So we'll come to the next case. So this is a 19-year-old unmarried. She has come to the OPT to discuss regarding the contraception. She doesn't have any significant medical history. She doesn't take any medication also regularly. She is sexually active with the male partners. So in this particular case, any other histories like Selvi madam, can you how are you going to approach her? You want to ask her any other history, or with this history it is enough for you and you want to go ahead with the consultation with her or counseling? Selvi madam, are you there?
Yes, ma'am. Yes, ma'am.
Yeah.
Yeah, she's unmarried, 19-year-old. So she may not tell us all the facts, even if we ask her directly. So we have to be very sensitive while talking to her. And so she says she's sexually active with male partners. We don't know how many male partners she has. Is she having a steady partner? How frequently does she have intercourse and all that? And does she have any other symptoms because of that? What is her practices? Like, is she following safe sexual activity? Like, is she using condoms? And
yes, she come to us to ask regarding what type of contraceptives she can use. So as you told, regarding history, already we have some history I have already given. So you have to always ask the 5 Ps. Regarding the partners, which is having a single or multiple partners, what are the practices, protection from the STI, and also she is having any past history of STI there or not, and the pregnancy prevention. So these are the 5 P we should ask to the particular adolescents when they are coming for the consultation for the contraception purpose. And you have to also give them a cafeteria choice. So what are the methods of short acting and the long acting contraception? And most of the adolescents, they use the short acting methods, like either the OC pill or male condoms or female condoms they use, and the most commonly used is the male condoms for the adolescent. Okay, so if Premlata madam, can the long acting contraceptives be advised for this adolescents?
Yes, she is sexually active, and you wrote it as partners. Yes.
Yes.
So maybe multiple. So it is better. Suppose she is not, the partner is not agreeing for condoms, or she is a person who is not taking medicines regularly.
Yeah.
Contraception, IUCD is more preferable.
Yeah. So even we have it previously, unmarried girls or adolescents or unmarried women, we should not put a long acting contraception either injectable or intrauterine devices. But there is it comes under the menarche to less than 20 years. You can use either copper IUD or LNG IUD also you can use. So that is no problem in using any long acting reversible contraception. And is it safe to use the intrauterine devices in adolescent?
yes. If she is sexually active, yes.
Yes, so it is safe. And even if all the guidelines like the ACOG, American Academy of Pediatrics, CDC, and everything, they support the use of the this long acting, particularly this intrauterine devices, because these girls particularly, they don't practice even if you tell the condoms or the OC pill, they don't use it regularly. So I think it is better for them to put either LNG IUS or a copper T. So that they, even if they are having, they will prevent the pregnancy, and also they will prevent the any other mostly for the prevention of the pregnancy. And we should also advise them for the dual use of the condom, so that they should not have the sexually transmitted infection. That is also more important. So when she is coming to approach us, we have to see 3 things. One is to prevent them from the sexually transmitted infection. Second is to prevent them from the pregnancy, so that they should not go for any unwanted abortions and all. Okay,
once we start advising about oral contraceptive, we have to counsel them very well and tell them these are the cyclical, means you have to take for so many days compulsorily.
Yeah.
Otherwise, what they do, okay, whenever they have sex, they take 1 pill.
Yes, madam. See, most of them take the emergency contraception pill, they make it as a regular contraception.
That is also there, and even in cyclical pills, they are taking 1 or 2 every
1
day.
or 2 pills, yes.
Yeah.
Even recently, I remember one patient, she is not an adolescent, she was a married lady. I think some unprotected intercourse happened, and she has taken 1 dose of overall L tablet. and she is asking whether pregnancy will happen or not. I don't know from where they got all these ideas, and they take medicine on their own. Okay, so this is the last case.
Actually, emergency bills are not available, isn't it?
Yes, ma'am, not available.
Yesterday only patient came to me. She's for last 6 years, she has been taking emergency pill every 2 or 3 months.
Yes, madam. Lot of patients are there that think emergency contraception pill, that is a method of contraception. So actually we have to educate them, like what are the methods of, you have to give them the cafeteria choice, and which is what are the pros and cons of the each and every method, so that whatever is suitable for them, they should like take that, like practice that kind of contraception. Okay.
Nowadays, that in injection, progesterone injection is also nowadays advisable. Previously, we thought that a bone marrow density regarding. Now there are lot of studies. Since she is sexually active, she can go even for a dual method.
Injectable also.
That is with the injections. Antara is freely available.
Yeah. So that is where this long-acting reversible contraceptions can be given to the adolescent like girls.
Are you saying for Depo-Provera?
Yes, madam.
Yes. DMPA.
Madam, DMPA. Yes.
Ma'am, with DMPA, lots of menstrual irregularities. No, ma'am. Irregularity should be told to the patient.
And we have to tell them there will be an irregularity.
Irregular spotting and
date when the next date when they should repeat the dose should be written and given, and if there's a follow-up for the date, it would be ideal. Otherwise, they come with irregular periods, over bleeding, and it becomes difficult.
Otherwise, also they will have with DMP.
Yeah. Yeah. So this is the last case, and she is a 15-year-old only child. Presented with, she came to my OPD with the irregular cycle. She came accompanied by her mother. Her mother, like when she entered into the OPD, she was continuously looking at her mobile, and just she came and sat. She didn't look at me also. She just came and sat, and her mother, then she started talking regarding her problems. Mother is a banker, and her father is a businessman. Both of them are very busy, and she is the only child. And then when I was just taking her history, I told just to lie down on the like couch. I just want to just do the examination. She went, just lie down, put her leg at her home, how you lie down. And immediately she started seeing the mobile. She was not leaving the mobile at all for even 1 or 2 minutes also. And when I was taking the history, her mother told she is having on antidepressants like SSRI and on clonazepam for last 2 years. She is only 15-year-old lady. So here I just want to ask Dr. Maheshwari, what could be the cause of this, her mental depression from, or any other history you want to take, or from the family history, do you find any risk factor to have this kind of symptoms, and she is an antidepressant for last 2 years?
Sunita, 1 minute.
You want to ask?
Sunita,
Yes,
1
ma'am.
minute.
Yes, ma'am.
Sahiti, who is there? Sahiti, you have to promote Dr. Vijay Lakshmi. I think Chitrakala is not there. Shield people, who is there?
Biji madam is raising her hands. In between I asked. Biji madam is raising her hand.
Come, no, they have to allow her inside. Who is there? Chitrakala is not there. Sahiti must be there, no? Shield people, who is there?
Shagadi is there.
Then Sahiti, please.
Ma'am, it says Sahiti left in between.
Left. That's the reason we are not able to allow Vijay Lakshmi inside.
Yeah, she has raised her hand 2-3 times, I saw. So in between I asked also. I didn't understand that part.
Sita, you are also a host, no?
Ma'am?
You are a co-host, no?
Yes, madam. Yes, madam. So I will.
You can allow them.
You can do that. Then you can allow Dr. Vijay Lakshmi.
Yeah. And I have to go through the participants, no?
But Josephine, are you there? Josephine? You have to go to the Dr. Vijay Lakshmi name and click there and make her as a host.
Okay, madam.
Just write the name in the column of find a participant.
Acha, BG madam, she has put, I joined in that only, not able to come as a panelist. Kindly promote me. Where is her name?
Her name is not there, la?
No, name is not there.
Not there.
Nothing can be done. Josephine has also left, I think.
It is as VG, ma'am.
Ah?
VG. She says it is VG, not Vijayalakshmi Gnanasekharan.
BG, but it is Josephine Jairani madam.
Also not there, ma'am.
Not
No,
there.
her name is Sel.
I will call Sahiti. Sunita, you continue. I will call
Okay, ma'am.
Sahiti.
Okay, ma'am. Okay, ma'am. Sure. Yeah. So, Dr. Maheshwari, so what do you want to ask? Any other questions to this particular patient regarding her this symptoms or behavior, and she's taking antidepressant for last 2 years? Dr. Maheshwari, are you there? Otherwise, Dr. Mahajabin, you can answer.
Can I?
Yeah. Ma'am, Chaya madam, please.
Yes, ma'am.
Yes, ma'am.
She's the only child.
Yes, madam.
And both
Her
the parents are working. Her
The
parents,
parents are not available all the time for the kid. Yes, ma'am. You go ahead, ma'am.
Taru madam, please, you go ahead.
The 15 years, she has grown up with a loneliness in her home, and nobody was there to understand her and to discuss with. So she has taken help of mobile. Now the mobile is the only friend, and the such friend which is not telling the truth and correct things to her, because whatever she wants, she can see. So this is the problem with her. So important is the parents are very busy. They don't have time for the baby. And she's the only one. There is no other sibling to share problems with. So the nuclear family has such problems these days. And when they have school may they have friends, but those friends are also the limitation of their knowledge. So they tell them according to their own specific knowledge only. So, and this is so important. So parents should have at least some time with their child, and putting her on antidepressants and lorazepam, this is also not the answer.
Yes, as you said correctly, ma'am.
They need psychologists, they need counseling.
Yeah. So if we'll see now globally, like 1 in 7 of 10 to 19-year-old experience of kind of mental disorder. And the 13% of the global burden belongs to this adolescent group. And they have depression, anxiety, behavioral disorder, and particularly I have seen it like even practically also we see a lot of students like adolescent girls or girl or boy, like they develop the symptoms because of many factors are there. So like if you see the family relation, so they have a very nuclear family. Nobody talks to like each other. And morning the parents goes, by the time they come in the night, the child will be sleeping. So they don't have any kind of interaction with anyone. So that is
child is awake till 4 o'clock and parent doesn't know.
Yes, madam. Yeah, they will be playing some game, something they will be doing till. And nowadays this habit of these adolescents and teens also very different. They, as you said, like they wake up till 2 o'clock, 3 o'clock in the night, and they get up at 11 or 12, like in the morning. So that is their usual habit. There is no proper breakfast, no lunch, no dinner. Whenever they get up, they eat something. So that is it is the story of the most in most of the families. So, and if you'll see, this is this all this depression or this mental disorders, 50% of the disorder starts from the age of the 14. That means at the adolescent young age, if we want to prevent them from this mental symptoms or the disorders, then we can prevent also any psychological symptoms or mental depression in the future life also. So then Dr.
Difference between two psychologists and psychiatrists.
Yes.
So we should not go to psychiatrist first, go to psychologist.
Yes, as you told, yeah. We should go to the counselor first rather than to going to the psychiatrist. So Dr. Selvi, can you mention some mental health determinants? Like what are the factors that determines the mental health of an adolescent?
Whether they have any, what are the kind of friends that they have, what are the peer pressure they are exposed to, and what kind of media do they watch. Nowadays, most of these children watch YouTube shorts,
yes,
which is It is hardly lasting a few seconds. And so their attention span also is kind of limited to that time only. They can't think more than that. And for everything is under their fingertip. For anything, they don't need to use their brains at all. Immediately, they will check on the Google and they will get an answer to whatever they want.
Yes,
And a lot of that media influence. And how is the home atmosphere? What is their relationship? Are they able to talk to the parents? Or are the parents able to connect with the child? So it's basically the parents who need more counseling.
Yeah, as you rightly said, madam, because we are not able to give that much of nowadays, most of the families, both husband and wife, both are working, most of the families, and all are busy. So we also don't actually, we should find some time to spend with them so that you'll explain them each and everything. As I told initially, adolescent, it is a phase of life that changes from one phase to the another phase. So a lot of curiosity is there having in their mind. So you have to talk to them, discuss with them. You have to bring them to our confidence so that whatever problem they have, they should share with us. Like even if the school and college, something happened, either any sexual events or any violence, anything had happened, so they should also feel free to talk to us. So in that case, whenever some problem happened with them, they are not able to speak out. So that time only all this mental depression or the anxiety, it comes.
And also this harsh type of, that disciplinarian type of, the disciplining on the part of the parent also doesn't work these days.
Yeah,
You have to draw a line somewhere between parenting and being a friend to the child.
Yes, madam. Yeah. So, Dr. Mahajivin, can you just mention how are you going to prevent such kind of mental problems for the adolescents?
Yes, ma'am. See, this should be a multidisciplinary approach, and we have to include the parents in our treatment thing. And whatever we are going to do, we have to explain to the parents first, and they should accept the fact that they are playing the major role in this case. And we need to involve the psychologist and psychiatrist in case if she needs a psychotherapy. And we should explain everything to the parent as well as to the child. And we can start the medication in case if she needs a medication, we can start the medication simply we can start with the selective serotonin reuptake inhibitors. And in case if she's having some other hormonal influences on because of this psychosocial problem, sometimes she may have hormonal imbalances also. We need to encounter on that. We need to do investigations in case if she's having irregularity in her cycles because of this because of the depression. So we need to check on the hormonal hormonal imbalances, and we need to encounter that.
Yeah. Charu madam, you want to add anything?
Yeah, of course, she has explained everything regarding this, and very rightly said that we have to counsel parents, but we have to counsel them separately and then together also.
Yeah, that is more important, as you told.
Because they have to make link in between. So we can be the link between them, and so that they can share things along with them also. Once the confidence is built up, then later on the treatment is automatically done.
Actually, to tell the truth, it's more difficult to convince the parents than the child, because they are so busy in their life thing that they don't realize that
they won't accept this.
They're fixed ideas also, fixed ideas. We are right.
Yes, that is true. Because I see a lot of parents with they used to fight in front of me. Like mother will be telling one thing and daughter will be telling one thing. So most of the time they start fighting.
Yes, ma'am. They'll be saying because of continuous screen, watching the screen, because of the screen only, she is having this kind of depression.
Yes.
They may not know that.
One more thing is comparison between herself and a child.
Yes.
See, our times we were not like this. This time you are like this. You don't do this. We used to do this. See, I tell them, please leave this. Your era is gone. This is different era. We have to accept that.
Comparing with the other also. She is getting so much of marks. You are not getting.
Yes, madam.
So active. Yes, that only depresses adolescent more.
The depression starts more. That is true. One problem.
Depression starts from home. They keep comparing, and I agree with Taru madam is that I was like that everyone are not like this. And they have a very nice memory of what they were.
Yeah. So adolescents, actually, they are the resources to be developed because they are the future of our nation. So if we want to adolescent health, we have to take care of much in terms of everything.
There was a case I sent the mother out. Please go out. I have to discuss with
Yes,
the baby.
ma'am. I also do that. I send the mother out saying on the pretext that I have to just check her. And the daughter also says, please ask
Yeah,
her.
many times you need to counsel the daughter and the mother in a different, not together. Sometimes you will counsel them differently. Again, you can separately, and then you can bring them together.
Them back together. Yeah.
Dr. Sunita, ask them to tell one word from each panelist and finish it. Ask them
Yes,
to
ma'am.
one word to the adolescents.
Yeah. Please give your concluding remark, like some advice to the adolescent. I'll start from Taru, madam.
What to say? Everything is covered, and this is very nice.
Just
topic.
one point.
Just help them.
Yeah. Okay. Then Pamela, ma'am.
More mental health is more important than the physical one. Physical things can be cured.
Okay, thank you. Dr. Selvi, madam. Selvi, madam.
We have to strike a balance, ma'am. We have to really strike a balance and become, get them to talk to us more than anything else.
Yeah. So, Dr. Maheshwari? Maheshwari is not there.
One more thing, Dr. Maheshwari ki side say, open up.
Yes, they should be open up. That is correct, madam. Mahajabin?
Yes, ma'am.
Yeah.
Yes, ma'am. If treating an adolescent is completely different from treating an adult, first we should gain the confidence from that adolescent.
That is very true. That is very true. So you have to gain the confidence of the adolescents before starting, because they should believe you. Then only whatever you will tell, they will follow. Otherwise, they won't follow at all. Even that
one word only.
Ma'am?
Dr.
One
Mahajabin.
word.
Yes,
Only one word.
One word.
Yes, ma'am.
Dr. Sovna?
Be my friend.
Ma'am, three things. One is spend quality time. Second thing is we should update on the current trends.
Yes,
Third thing is listen more than giving advice or talking. Listen more to our children so that, we update and we know what is the current trends, and so that, we are the persons who should change. They will never change. That's what I feel.
Yeah. So Dr. Sumitra?
Not to be prejudiced against their sexual activity, because they are come with that sensation that the doctor is not going to listen to them. And so you need to be sensitive to that.
Yeah, sure. Sampath madam, your final comments. Sampath ma'am.
My final comment, always give information to adolescents, don't advise.
Yes, that is true. We should do more of awareness, like campaigning, rather than giving them advice, particularly in the schools and the colleges. We should do a lot of awareness programs for them. Yeah. Because
thank you.
Yeah. Thank you, madam. Thank you for the opportunity. I thanks all my panelists for a very nice interactive session. All are very active. I think everybody has given some points which can be can be taken as a take-home message. Thank you so much, all the panelists. Thank you, Sampath madam. Thank you, VG madam and Jairani madam.
Sampath ma'am, I have a question.
Yes.
Apart from all this, these days I am finding very rising trend of serum prolactin in adolescents. What may be the reason?
Maybe thyroid.
No, thyroid is normal. I
Normal,
get
yes,
both the
that is
things
true.
together. Thyroid normal, still prolactin is high. Maybe
many times
rising prolactin levels may be because of continuous usage of proton pump inhibitors also.
So, yeah.
Because of those diets, keto diet and paleo diet, they will be having gastritis. Because of that, they will be taking continuous proton pump PPIs. This will cause hyperprolactinemia, ma'am.
Despite all these are not there. Still, the prolactin is high.
We have to do something. Take the statistics and analyze the
sleep also.
Do you think
the
role of milk
also?
Ma'am, one more thing, what time, madam, one more thing, when they take the test, actually, if they have not slept overnight,
Yes,
that is more important. So
That
prolactin,
also.
when that's what you should advise them to take the mostly in the empty stomach in the morning, and they should have a good sleep, no exertion on the previous day. All those things are also there. That also like,
Hey, ma'am,
Yes.
we do take care. Morning is 7,
In
8
our
a.m.
places, we don't
7:30
see.
to 8:30 a.m. serum prolactin after good sleep. Because that was the highest level of prolactin at that time.
If you can do one study, in
Yes,
our
madam.
places, we don't see that. If you are having means, you can have a data.
Yeah, because we have a general idea whenever there is a hypothyroidism, prolactin level will go high. That connection is there. But
Okay,
whenever
ma'am,
you
I'll
see
let
only
you know the
isolated
study.
hyperprolactinemia,
I will
think,
collect the data and let you know.
yes,
Yes,
madam. Sure,
definitely.
sure.
Thank you, Sunita.
Thank you,
Thanks
madam.
for wonderful panel with the
Thank
great Rajasthan Society panelists. And Dr. Vijay has mentioned all thanks, starting from Jairani, Kundavai, chief guest, and speakers, Nivedita. So since she was not able to enter, she has given the all thanks in the message, and to the delegates who are there for till up to 9:30. Really, only one thing, as usual, Dr. Vijay has missed is always she will thank God first. So on her behalf, I'll thank God and all. Thank you. Wonderfully.
Thank you so much, madam.
Thank you so
ma'am.
much.
Thank you.
Thank you so much,
Dr.
madam. Thank
Thank you. Thanks for the opportunity, ma'am. Thank you.
Thank you for the opportunity, ma'am. Thank you very much.
Thank you.
Bye.
Ma'am. Thank you.
Bye, Sambar.
Bye.
Jairani. Yes, Jairani.
நான் கேட்டுட்டு இருந்தேன் உங்க பேனல்லாம் நீங்க கொஞ்சம் லேட் அங்க ஒரு பேனல்ல பேனலிஸ்ட் இங்க ஒரு பேனல்ல மாடரேட்டர் உலகம் சுற்று வாலிபி மாதிரி வெபினார் சுற்று வாலிபி ஆயிட்டீங்க
Bye.
Thank you, Taru madam. Thank you, Taru madam. Thank you for the lovely interactions you all had. Enjoyed everything.
Look, my
all of you, please vote for
Oh,
Jairani.
that's lovely.
Ma'am,
That's
it's very
lovely.
nice. Your mehendi is very
That's lovely,
nice.
Taru.
Yeah, very nice.
Oh, pretty.
Very pretty.
Okay. For
Anyhow, so
adolescent
nice.
sexual health to be good, vote for Jairani.
Yeah. Kindly tell all your friends to support me, madam.
Yeah, sure, madam. Ma'am, you will win. Don't worry.
Hopefully.
Thank you. Bye. Good night.
Thank you.
All
thank
right.
you.
Okay.
Bye.
Anyhow, nice. You had a good, very good panel, and really every point is very practical, very useful for all the gynecologists here. And almost all the panelists are very active and they are very crisp, and it's so nice to talk of various aspects. Sunita and Sambat, it's really good that you put forth everything about adolescence in a beautiful way, which is very useful. Definitely very practical approach.
You are the inspiration, Sampat madam.
Yeah, Sambat always.
Yeah. Thank you, ma'am. Bye, ma'am.
Okay. Anyhow, thank you so much. Thank you. Bye. Thank you, chairpersons. Thank you, all the panelists, and thank you, all the moderators. It's so lovely.
Thank you, ma'am.
Very informative, interactive, and enthusiastic participants. Very good. Thank you.
Thank you. Okay, bye.
Bye.
Vijay, if we are closing it, Vijay is not there.
Yes, who is the Josephine is the host. I think Sunita, you have to close it.
Yeah.
Shakti is also
You are in
not
the
there.
adolescent committee, no? Yeah.
Okay.
Anyhow, thank you, Sahiti. Sahiti, very much thanks.
There, okay.
Yeah.
Bye.
Bye.